Thank you, Mr. Chairman. Good day, colleagues, speakers, and students. Today, I'd like to talk about the reciprocal causal relationship between laryngopharyngeal reflux and Eustachian tube obstruction. My own experience in the medical treatment has proved that many cases have both laryngopharyngeal reflux, or LPR, and Eustachian tube obstruction, or ETO, at the same time. I reasoned that ETO can be a cause of LPR, or conversely, LPR can be a cause of ETO. And I realized keenly the necessity of defining the cause and effect relationship between both of them, and it should be universally applicable to management of many cases of this type. And I will introduce Eustachian tube catheterization using devices like a Eustachian tube catheter and a Toynbee diagnostic tube. Blocked Eustachian tubes or Eustachian tube obstruction can cause several symptoms. These symptoms can be regarded as major multiple symptoms originated from ETO. Although ETO is one of the principal causes of hearing loss and/or ear fullness and/or vertigo and/or tinnitus and/or headache, including otalgia, has already been recognized by many well-respected senior doctors for a long time. It has still received only scant attention, both in the literature and in practice. Some mentions that an example of dizziness induced by middle ear pressure fluctuation is alternobaric vertigo, such as occurs in people who can clear one ear but not the other. This is mainly a problem in scuba divers and airplane pilots. They think that pressure sensitivity is a symptom, not disease, so it tends to be regarded as normal variant. However, we need to study a question in its broader aspects, especially in the cases complaining nausea, vomiting, and perspiration, accompanied concomitantly by vertigo, which are attributable to ETO. Their physicians tend to fail to recognize the cause in the emergency room or outpatient clinic. What's even worse, many special clinical tests of vestibular function are performed even in the case such as vertigo due to ETO. It is true, of course, that there are many other conditions which may cause vertigo, but since obstruction of the Eustachian tube is one of the most obvious and also the most easily corrected, every patient with symptoms of dizziness and/or nausea and/or vomiting and/or perspiration should be subjected to the therapeutic test of inflation of the tubes as a first step in a thorough clinical investigation. Dizziness or vertigo from ETO can be explained by an increase of inner pressure of the vestibular organ. It is because negative middle ear pressure gives rise to the retraction of the tympanic membrane, and it makes the stapes push against the oval window. You can watch the perilymph, orange-colored area, and endolymph, blue-colored area. It seems obvious that Obstruction of the Eustachian tube somehow disturbs the air pressure and causes stimulation of the pedal lymph, which interferes with the normal balance as maintained by the labyrinthine mechanism. The otolithic membrane is part of the otolith organs in the vestibular system. The otolith organs include the utricle and the sacule. The otolith organs are beds of sensory cells in the inner ear, specifically small patches of hair cells. Overlying the hair cells and their hair bundles is a gelatinous layer, and above that layer is the otolithic membrane. The utricle serves to measure horizontal accelerations, and the sacule responds to vertical accelerations. The reason for this difference is the orientation of the macula in the two organs. You can watch the utricle and the sacule. It seems likely that this syndrome due to ETO is either caused by asymmetry in inner ear pressure accompanying changes in middle ear pressure, or due to displacement of otolithic membranes associated with displacement of the oscular chain accompanying an inequity between middle ear and external ear pressure. The linear acceleration could be in the horizontal direction, as in a moving car, or vertical acceleration such as that felt when an elevator moves up or down. Recognition of the head's movement relative to the body is provided by the linear otolithic macula and angular semicircular canals acceleration receptors of the inner ear. Electrical activity generated within the inner ear travels along the vestibular nerve, primary afferent neuronal pathway, to the central vestibular nuclei of the brainstem, forming second-order neuronal pathways that become the vestibulo-ocular reflex, VOR, the vestibulospinal tracts, and the vestibulocerebellar tracts. Pathways derived from vestibular information also travel to the brainstem emetic centers, or nucleus solitarius, blue-colored area, which serves to explain vegetative symptoms such as nausea, vomiting, and perspiration that a patient typically experiences following an acute unilateral vestibular ulcer originating from acute unilateral Eustachian obstruction. This acute unilateral vestibular ulcer can be from acute unilateral Eustachian obstruction. We can realize that electrical activity generated by ETO travels to the brainstem emetic centers and cause vegetative symptoms such as nausea, vomiting, and perspiration after all. In order to explain the mechanism of vertigo originated from Eustachian tube obstruction, it can be summarized in regular sequence as follows. Changes in middle ear pressure and negative middle ear pressure, and an inequity between middle ear and external ear pressure, and retraction of tympanic membrane, and displacement of the oscular chain, and the stapes push against the oval window, and stimulation of the pedal lymph, and increase of inner pressure of vestibular organ, and displacement of otolithic membranes, and asymmetry in inner ear pressure, and loss of unilateral vestibular function, and interruptions of vestibular reflex pathways and interferes with normal balance as maintained by the labyrinthine mechanism. Here, we need to remember this clear proposition that ETO is the obvious cause for loss of vestibular function. With a loss of unilateral vestibular function, the patient acutely experiences the sensation of true vertigo from interruptions of VOR pathways and tends to lie perfectly still, as any movement aggravates vegetative symptoms such as nausea and vomiting that rise from the emetic centers. The stigmus beating away from the side of lesion is the cardinal physical sign that obeys Alexander's law. Interruption in vestibular spinal tract pathways cause the patient to fall or list toward the affected side. Findings of ipsilateral hemispheric cerebellar dysfunction presenting with behaviors such as fast pointing, an inability to perform rapid alternating movements, dysdiadochokinesis, and gait ataxia reflect acute vestibulocerebellar tract involvement. The vertigo is caused in most instances and perhaps in all by unilateral Eustachian obstruction or by more complete obstruction on one side than the other. The direction of the gait furnishes a clue to the side which may be affected, for in most of the cases the steering is in the direction of the obstructed side, with compensation implying the existence of normal functioning CNS and contralateral peripheral vestibular system. There may be minimal symptomatology that is only brought out by very rapid head movements. The spontaneous nystagmus disappears, vegetative symptoms resolve, gait improves, and in the case of a chronic condition, the patient may experience only a slight imbalance when turning quickly. This point can be the reason why any vestibular function test should never be performed before correction of ETO and without normalization of middle ear pressure and tympanic membrane retraction. Bilateral peripheral vestibular os vertigo is not a feature of bilateral vestibular os, even when it occurs in an acute fashion. Injury to the end organs, as might occur in systemic aminoglycoside vestibular toxicity, causes a bilateral loss of functioning that tends to be electrically symmetric at the level of the vestibular nuclei in the brainstem. Instead, the patient tends to complain of oscillopsia and imbalance. The gait is typically broad-based and ataxic, especially with eyes closed. Falls are not infrequent, and in many instances, the patient requires assistive devices for ambulation or is relegated to a wheelchair. Compensation is generally unlikely to occur despite the best efforts of vestibular rehabilitation therapy and a greater reliance on information from visual and proprioceptive receptors. Now, it is reasonable to ask some questions. What are the normal parameters of middle cavity pressure that does not have an impact on vestibular function? What is the normal criteria for difference of pressure between both middle ear cavities that does not have an impact on vestibular function? So, what is the reference point in order to differentiate between unilateral ETO and bilateral ETO? While vertigo originated from ETO is a distinctive clinical entity, doctors ignore the possibility that the violent symptoms of dizziness, nausea, vomiting, and perspiration can be originated from ETO. The reason is that some of the physicians, audiologists, otolaryngologists, or even otologists are likely to think in terms of disturbances in the digestive, circulatory, nervous systems, or only vestibular organ function, and usually examine them without considering other possibilities. As the result, they miss both the diagnosis and treatment for ETO, and these cases are so consistently overlooked. When the onset of the symptoms of nausea and vertigo is sudden and severe, the diagnosis is more easily established, and if the proper treatment, Eustachian tube catheterization, is instituted promptly, the relief is striking and dramatic. In an acute case, it doesn't matter if the obstruction of the Eustachian tube is unilateral or bilateral. The cases of insidious onset are the ones most likely to be overlooked. In these instances, because the gastrointestinal symptoms are predominant, the patients are likely to be subjected to various types of treatment of long periods for diseases of the digestive system. The gastrointestinal symptoms of the cases of insidious onset can also be regarded as symptoms of LPR or GERD. Hence, we can accept an Cartesian intuition that every variable symptom and disease associated LPR or GERD should be included in the multiple symptoms and disease originate from ETO. We must pay attention to the necessity that the cases of insidious onset are subjected to Eustachian tube catheterization first. Symptoms of LPR are diverse and include intermittent dysphonia, chronic throat clearing, excessive throat mucus, sialorrhea, cough, the sensation of PND, cervical dysphagia, dysgeusia, halitosis, throat pain, the sensation of a lump in the throat. Other manifestations in the head and neck that have been reported include asthma, sinusitis, and otitis media. I believe that more variable symptoms related to both of LPR or GERD, e.g. back pain and numbness of fingers or toes, than many symptoms gaining academic recognition at present need to be proved definitely. On the grounds that LPR or GERD can be the direct result of ETO, I strongly urge that ETO should be included as a direct cause of LPR or GERD academically. In the patients having both LPR and ETO, ETO is not just a cause of LPR as seen above. On the contrary to this, LPR can be a cause of intrinsic mechanical obstruction of Eustachian tube. Because reflux contents from stomach can reach the nasopharynx and the Eustachian tube through esophagus and block the tubes directly or cause inflammation of the mucous membrane lining of the Eustachian tube or adhesion and collapse of it. Recently, several studies have shown an association between gastroesophageal reflux and otitis media with effusion, and the conclusion that LPR plays an important role in the pathogenesis of OME, as gastric reflux reaches the middle ear through the nasopharynx and Eustachian tube to cause OME. It seems obvious that reflux contents from stomach can reach the nasopharynx and the Eustachian tubes through esophagus and block the tubes directly or cause inflammation of the mucous membrane lining of the Eustachian tube or adhesion and its collapse. Therefore, the concept of reciprocal causal relationship both of LPR and ETO, which cause a vicious cycle, is established distinctively. Treating patients regardless in an emergency room or outpatient clinic, a wide and diverse variety of symptoms originating from LPR or GERD and ETO has to be considered with the mutual connection observantly. This procedure is more than a century old and was earlier routinely done to check patency of the Eustachian tubes. As mentioned earlier, because Eustachian tube catheterization may be of both diagnostic and therapeutic value, they should be subjected to the therapeutic test of inflation of the tubes as a first step in a thorough clinical investigation. Moreover, it is established that every clinical test being used in the assessment of vestibular function should be performed in the state of ideally normal middle ear cavity pressure, with a perfectly equal balance between both ears. Any vestibular function test should never be performed before correction of ETO and without normalization of middle ear pressure and tympanic membrane retraction, because ETO can already cause a loss of an abnormality of a vestibular function. Surely the results of vestibular function test without checking ETO and the middle ear pressure must of necessity to be just the infinite errors. This is me. I'm practicing Eustachian tube catheterization in my private clinic. Thank you. I'd like to thank you very much for your attention.